I want to open up the presentation and thank everyone for joining us tonight. I am really excited. We've got a panel of experts in the field who actively treat patients with head and neck cancer. So we're going to be going through some case studies this evening, and then at the end, we'll have an open forum for Q&As. But if you do have questions throughout, feel free to pop them in the chat box and we will answer those as we go. This is Brooke Beelman. I am the moderator this evening. I am a medical speech pathologist with experience in the acute care, inpatient, outpatient, and skilled nursing settings with a special interest in dysphagia and head and neck cancer. And I'm really excited that I just recently accepted a full-time position with the Tactile team. Next, we have Joy Hussey.
Hi, my name is Joy. I've been a speech pathologist for 30 years, and the last 25 I've spent with a large otolaryngology practice in West Des Moines, where I specialize in professional voice and then also head and neck cancer, dysphagia. I have a mobile fees unit as well, and I'm excited to be here.
Thank you, Joy. And Shelley?
Hi, I'm Shelley. I have been a physical therapist for over 30 years, and I've been in lymphedema for the last 20-something years. And I am currently in St. Louis, Missouri at Mercy Hospital, St. Louis, David Pratt Cancer Center, where I am a head and neck lymphedema specialist, and I also am certified in oncology rehab. And I'm very happy to be here today.
Thank you, Shelley. And Crystal?
Hi, my name is Crystal Tallman. I am a dietitian at Mercy One Cancer Center in Des Moines, Iowa. I have been a dietitian for 13 years and have spent 12 of those years specializing in oncology nutrition. So very happy to be here as well.
Thank you. So we have a couple of disclosure statements and our first poll question. So we want to get to know you all. Who do we have in the audience?
Come on, PTs.
Excited to see a lot of students too.
Yeah.
Woo!
It's encouraging.
Yes!
Good win.
So it looks like we've got a variety of clinicians and some students on the call tonight. So that's super exciting.
Oh, and we have a nurse practitioner also.
Yeah, that's great.
All right. Okay. So we know that lymphedema is within the scope of practice for us as clinicians. However, a question that I frequently see online from a speech pathology standpoint is lymphedema in my scope of practice? So Vanderbilt did a study in 2016 in which they demonstrated that 90% of patients treated for head and neck cancer develop lymphedema 1 year post-treatment, which we know that lymphedema can result in dysphagia, pain, discomfort, difficulty breathing, and more. So Crystal, do you want to give a little bit of information on this slide?
Yeah, so when I first started in my practice 12 years ago, our radiation oncology practice did not have an established relationship with PTs, SLPs, or anything like that. Recognizing the importance of those players on the team, I worked on setting up a relationship with the SLP that was affiliated with our hospital's outpatient rehab clinic. So we sent all of our head and neck patients up there up front. So we made it basically after they had a consult with the rad-onc, we would send the patient over ideally before treatment or within the first week of treatment, so they could get swallowing exercises and get some of the basics laid out and have that baseline assessment. After we sent patients to that hospital affiliated site for a while, we're getting patient feedback that the interventions were kind of stale. The patients weren't really getting a lot out of it. And we had some other patients that lived closer to a different practice in our town, which was not affiliated with our hospital, which is actually how we met Joy, who's one of the other panelists. We found that Joy is very forward thinking in this field and just did a lot of interventions and did a lot of creative things that we weren't experiencing with the other practice. So we started basically using her practice exclusively for our SLPs. I just want to bring that up just to highlight the importance of the SLPs and the work that you guys do. and the OTs, the CLTs. It's just very much a team approach, and there's definitely the work is out there for you, and it's probably just sitting at your doorstep waiting for you to help out.
Yeah, I agree. Thank you so much. Okay, so Joy's going to walk us through some examples of different presentations of lymphedema.
Okay, so I think obviously we have seen pictures like this, and I always, at this point, like I just did not understand that this external swelling, this lymphedema, leads, like, is a precursor to fibrosis. And, you know, I don't know if it was like just me, but I know that the ENTs that I work with also just really didn't have that understanding that this isn't just edema that will go away, because that's what they would tell patients, you know, it's going to get better, just give it some time. But like, we can help this, and then we can also help the progression of this horrible disease later on. And so, you know, we start with the external swelling, and then, you know, as in speech pathology, we used to call this a woody neck. And I'm sure, Shelley, you've heard that term, you know, because their neck feels like wood if you have no intervention. And so,
that's a good point, Joy. I know in that Vanderbilt study that Brooke referenced, they also saw a large amount of patients had swelling and fibrosis even before they saw radiation. And so a key is identifying it early. And now that the Starling's law has been revised, we know that any swelling that's present longer than 3 to 4 weeks has a lymphatic component to it. And so these patients post-surgery that are presenting with swelling that's lasting longer than 3 weeks really could stand to use intervention from the CLTs to prepare them for radiation, or else it's just going to get worse. And, you know, it can very subtly start out as some swelling. Really, it might not look like a whole lot of swelling, but you should be able to feel the tracheal rings. And, you know, if you can't, then there most likely is swelling on the neck. And it very quickly can go to fibrosis.
good. Okay.
I'm going to go to the next slide so Joy can show us what a patient might look like under imaging.
Okay, so speech therapy friends, here we go. So if you're used to looking at endoscopy, I just want to do a quick, for my PTOT, everybody else, if you're not used to looking at endoscopy, to the left is kind of a normal looking larynx. So you're standing in front of somebody and you lop off their head, and now you're like looking down inside them like that. And so that's this image where you can see base of tongue, nice little epiglottis. The vocal folds are like little tiny white bands. Everything looks like very pretty and clean, and no swelling, you know, from the front to the back. And then with treatment, either sometimes during treatment or, you know, later down the road, this is what can happen internally. And so speech pathologists, if you are not doing fees, or if you're not looking and you're in a hospital setting, you should absolutely be doing fees. And so I'm a huge advocate and proponent of speech pathologists doing endoscopy. ENTs and the radiology guys will look, but they're not identifying this. And so I feel like we need to do a lot of educating on the importance of identifying internal swelling early on, so that then this doesn't progress to the really severe fibrosis. Go ahead and advance that slide. Here, I wanted to point out that it's not mutually exclusive. Like, you can have external lymphedema and no internal lymphedema, and you can have the opposite, where you can have very severe internal swelling and really not a lot of external swelling. And I think Shelley wanted to jump in here.
Again, as I mentioned earlier, the swelling can be very subtle, and mostly it's identified through palpation and pitting to stage it. Doing the pitting test. And so it might not appear to be very much swelling, but In that same Vanderbilt study, the majority of patients had both internal and external. A small, the minority had one or the other. So I always tell my patients that if you have swelling on the outside, you most likely have swelling on the inside.
And I did want to mention that really there's only one scale presently that even rates internal swelling. It's called the Patterson scale. And so if you're not familiar with that, go look that up and start using that, because it's a great way to track and monitor, are they developing slowly some internal swelling, a few months down the road, so that we can identify that early. Okay, go ahead and go to the next slide. So this is my patient. This is really the reason that I'm here. And if you've ever treated a patient with really severe fibrosis, it's heartbreaking and will haunt you forever. And so this is what happens when we don't treat lymphedema. And again, I did not know that lymphedema was the cause. And so I'm so hopeful that now that, I won't have any more patients that progress to this. And so this is what severe internal fibrosis looks like, where the base of the tongue basically melts away. He can't swallow, he can't talk. His vocal folds are completely paralyzed, closed. So the quality of life towards the end is just so horrible. But I'm hopeful now that I'm, being very progressive and helping to identify this and getting them appropriate treatment with manual therapists, and then watching them on the inside, that I won't have any patients that progress to this, especially my young people that are in their 40s and, hopefully living 30 more years. And so I'm super hopeful that we won't have any more patients like this.
It is heartbreaking. And oftentimes these patients are in a lot of pain, especially with tracheostomies or laryngectomies. The neck strap will prevent the swelling from escaping. And so they end up going chronic swelling and fibrotic very quickly. That leads to pain. So we do have to really keep a close eye. A lot of times for these patients, I see them chronically every 2 to 3 weeks, and it can go on for years because they are not able to manage it themselves to help improve their quality of life.
So we just want to hit home the point that the patient should be at the center of everything that we do. These are obviously complex cases that require interdisciplinary collaboration. How do you all see interdisciplinary collaboration fitting in your practices?
Well, I'll start with that. So generally speaking, at least in Joy and my relationship, we usually tend to see the patients first in our practice. So then, like I said, we tend to refer out to her ideally before treatment or within the first week or so of treatment. She'll be able to get them in. She can usually get a pretty quick turnaround time. And then as patients start their treatments, we will communicate as needed during treatment. It's not generally a whole bunch during treatment because they're kind of primarily seen by us, and then Joy does a lot of the manual drainage during that point, and the massaging after treatment is when Joy and I start talking a little bit more. Check in every once in a while, especially as we start to see changes in terms of their advancements of their diet or changing of textures. She helps guide me on the appropriateness of the textures, and then I can help jump in and help with the giving patients ideas on the types of foods they can eat that fall into that texture, and then also help with the transitioning off of the tube feeding if they're at that point.
Yeah,
that's great. I also have started doing prehab recently, where when cancer is identified, the surgeons give a referral, and I'm able to talk them through nutrition, basic nutrition, and I find out if they need a diet consult, and then also encouraging exercise. I start that process on the phone before the patient ever gets their surgery. And then it's followed up again by the speech therapist who sees them usually a couple of weeks post-op. And so we're in communication with the patient and with each other. My speech therapist and I work very closely with the patients on a regular basis of just making sure that their needs are being met. I'm watching their weight to see if they're putting on weight, and if not, we'll send them back to the dietitian. So every stage, the communication as a team is so important.
Mm-hmm. Okay, and I would add that, like, again, I try to start prehab as well with, it's called Faringo-size exercise program. There's a lot of research behind that with efficacy. And so getting them to buy in very early and making sure they understand the importance of this, that, you know, number one is curing their cancer, but number two is getting them to swallow again and getting back to normal diet. So
You're so good, Joy.
I'm strict.
So now we're going to get into some case studies. So we have 4 cases this evening, and each one is from a different perspective. So I am going to hand the floor over to Shelley.
So this case is a 53-year-old female, has a history of asthma, COPD, GERDs, hypertension, and she smoked cigarettes about a pack a day for 30 years. She presented with moderate hoarseness, difficulty swallowing, and pain in her right ear for about the previous 4 months. Diagnosis was established through biopsy and scoping that she had squamous cell carcinoma of the epiglottis, and she was treated with concurrent chemotherapy and radiation. About 3 weeks into the radiation, she was not able to take anything through the mouth because of severe pain, and she had lost 6 pounds over the past 3 weeks. And so they ended up putting in a PEG tube, and she had intervention of speech early on, and then I saw her about 6 weeks after her final radiation and concurrent chemotherapy. Midway through, she also received a Flexitouch. If you can go ahead and go to the next slide.
So these were images that Shelley was able to obtain for us. On the left, you can see the pre-treatment images in comparison to the right, where the mass was removed.
Very good. And then in presentation and the evaluation through palpation, I was able to stage her lymphedema through using MD Anderson scale, and she was in various areas 1A to 2, with moderate severity of the head and neck, as well as mild scar tissue and fibrotic restrictions, which impacted her efficient lymphatic drainage and range of motion. Her reason for getting therapy was pain, swelling, and burning. Of course, early on, she had terrible increased mucus production that patients often really complain about that, but it does subside as they get further away from the radiation. Next slide, please. So we're going to do another poll. Looking at the patient pictures, we want to know what type of intervention you would have recommended for this patient. So there's manual lymph drainage, compression garments, lymphatic pumps, all of the above, or something else. Oh, you're good. All of the above, 1 out. So 94% of you recommended all of the above. Good job. And that's exactly what she was treated with. Or 96% of you. So my goals for her, or the patient's goals, were to, of course, reduce swelling because she wanted to eat again. She wanted to reduce pain. Her throat was constantly irritated, and she was trying to clear it but couldn't cough up the mucus. And then my goals, of course, were to improve range, decrease pain and swelling, and patient to become independent in management of her lymphedema. So a plan of care was established 2 times a week for 4 to 8 weeks. And then usually, depending on how the patient is doing with managing their own swelling reduction, I will decrease them to 1 time a week or 1 time every other week as they become independent in self-care. But this all happened during COVID, and we had just had a reduction in force. So her first month of treatment, she did only receive therapy 1 time a week. We didn't see a huge significant results in decreased in swelling, but that second month, we saw her twice a week, and we did see much more significant improvements. On the next slide, you can see all the measurements that were taken, but you'll notice that her range of motion improved, her composite neck scores from MD Anderson composite by, excuse me, by September, she had gone down 5%, 5.3%. Her facial composite remained about the same, but that did continue to go down by November. Her trismus improved to normal. Her neck circumference decreased. And when I'm saying neck swelling circumference, I'm actually looking at the outer range of the swelling or fibrosis. And so she really greatly improved. Now in October, she actually had a car accident where she was only seen once every 2 weeks. And so we did have some problems where we couldn't treat her, but she did have her Flexitouch. She got that in the middle of September, and we still saw a nice reduction in her neck and then also in her facial swelling with just use of the Flexitouch at home. But you can see on these pictures, she definitely went down, her quality of life was better, and obviously she went back to work, which was one of her goals. So she was ecstatic.
Yeah, thank you very much, Shelley. So our next case is from the perspective of a speech pathologist. This is a case that was submitted to me from an SLP in the outpatient setting. So as we know, sometimes in the outpatient setting, we will get referrals with not an extensive amount of information. So this is an ongoing case, which is why we will be presenting this to the panelists. So this patient was referred to an outpatient speech pathologist just a few weeks ago. He had been treated for base of tongue cancer back in 2000. When he was referred to the SLP a few weeks ago, he had been NPO for about 8 months and had had a G-tube placed due to the fact that he could not obtain nutrition and hydration orally. So he was referred from his primary care physician for a video swallow study. So I won't go in depth as to the results of the video swallow study. If you want to screenshot or look at it on the replay, feel free to. But basically, what you need to know is that the patient had impairments in the oral and pharyngeal stages of swallow with laryngeal penetration and aspiration present. So with just this preliminary minimal information, Joy, what would you do in a case like this?
Okay, so I think with people like this, number one, we need to remember that head and neck cancer patients are going to aspirate. And you need to go in knowing that, and that I'm not going to say it's okay to aspirate, but we need to know, first of all, what's safe for them to start to take by mouth. And so, if I don't get the appropriate information from the modified barium swallow, I will do a FEES. I do FEES all the time. And I find that it's helpful not only for me, but also for the patient to see, because a picture is worth so much more when they can actually see, this is what I'm talking about when the food is sitting at the back of your tongue, and this is why we need to do these exercises. I think it's important to mention here as well, this was 20 years, and this is internal fibrosis at its best. And this is such a sneaky, insidious fibrosis. It's super sneaky because it happens very slowly and kind of seductively. And what do they start to do? They start to, as the base of the tongue goes away, they start to take a liquid wash. And then they start to take smaller bites, and then they start to eat softer foods. And so everything that they're doing is contributing to fibrosis and long-term swallowing trouble. You know what I mean? They're not purposefully doing that, but literally they're kind of allowing this to happen by default. They're doing everything wrong as far as exercise and science and all of that. So part of it is then convincing them that these people, we can make better speech pathologists. Then we just have to go back and retrain the muscles and strengthen them. And no liquid wash, larger bolus to add the load. And, it just goes back to really basic exercise science, what the PTs know really well.
Yeah, I love that you included that because I think that's so important. Shelley, from your perspective, if you had a patient referred to you this long post-treatment, would that change how you evaluate or treat?
My evaluation would be very similar to all of them. I mean, I wouldn't change it up that much, but knowing that he is 20 years out, the radiation damage is probably more severe, and the fibrosis is significant because he's been radiated. There might be some spinal stenosis. There might be he might have some nerve damage or palsies going on. Very quickly can go to thoracic outlet. And so, I would do my normal evaluation of range of motion of the neck, shoulders, trismus, test strength. I would do circumferential measurements of the neck and point to point of the face. I always get facial measurements at least once, even if I don't think that there is facial swelling, just in case. And then palpation is key here, of knowing where the fibrosis is, how severe it is, and documenting very carefully all the areas with staging it from the MD Anderson scales. And then also with these patients, very key is a posture assessment, because not only is everything tightening up, but these are the people that are going to be drawing forward. And so we really need to work on correction of the posture and pulling those shoulders back to prevent the thoracic outlet syndrome.
Yeah. Crystal, is there anything you want to add from a nutrition standpoint?
Just knowing that he had gone about 8 months without taking really much of any nutrition in, just make sure that when he starts his tube feeds that he'd go really slowly. We don't want to overwhelm his system with too much nutrition at once. That'll be a really gradual process. And then making sure that he's meeting all of his needs, primarily calorie, protein, and fluid needs via his formula, and that he's tolerating it well. And then once he's hitting that point, I'm pretty much on cruise control, and then kind of turn him over to the SLP. I would be checking in intermittently, but obviously there'd be a lot of work to do with this patient. So I'd probably be pulled back in if and when he's able to advance his PO intake.
So we have another poll question. Which instrumental evaluation would you recommend for a patient with head and neck cancer? Video fluoroscopy, FEES, or both? So we have a couple more seconds. And Joy, I'm with you. If I have to choose between the two, I would definitely choose FEES, but when possible, both is obviously awesome. Awesome. So 90% of you all said that you would recommend both if possible. Okay, so just in closing up this case, based upon the outpatient video swallow study, the patient was diagnosed with severe pharyngeal dysphagia and recommended to continue NPO with an ice chip and water protocol, oral care, referral to outpatient, and to CLT. So I am going to hand it over to Joy for another SLP case.
Okay, so this case is probably the most involved, I would say, because this patient had basically all modalities of treatment. They had extensive surgery. They had also chemoradiation. And so as you add treatment modalities, then the likelihood of having lymphedema and really significant problems with the swallowing goes up. And go ahead and go to the next slide. So this patient has basically, almost all of the patients that we see with head and neck cancer are going to have swallowing issues through every phase of the swallow. You know what I mean? Like all of them will have oral phase issues. They'll all have pharyngeal phase, and most of the time also esophageal issues. And so when you look at, a modified or, it's kind of, they're all a little bit the same because everything is reduced and it's weak. And so you get this kind of big global picture of, this is what happens to kind of all of them. And so we need to treat every single level of that and be aware of the issues and treat it kind of holistically. And so go ahead and go to the next. So my patient's goal was get this blankety blank tube out of my stomach.
Don't they all say that?
Yes. And my goal is obviously to get that a safe swallow and then the least restrictive diet. And for this gentleman, he has only 2 teeth. And so we had to go, I know that he probably won't get to like a hard masticated food, but hopefully to get to, soft masticated and minced kind of stuff. He was kind of a little bit up and down like Shelley's, where we had interruptions with various things. I tried to see him once a week, and I continue to see him now as we're advancing. Go ahead and go to the next slide. And so, here's our poll question. So what intervention would you recommend for this patient, or what would this patient be doing at your clinic? So traditional therapy would be, Shakir, Masako, continue NPO. Good.
Wow.
We have such a smart group. That's awesome. Good. Okay. So go ahead and, so everybody agrees that like all bets are off. Like hopefully we're doing all of the above. So I have to say that I went to a myofascial release course maybe 10 years ago, and it completely has revolutionized how I practice as a speech pathologist. And so I found it so efficacious for this population. So myofascial release is a big part of what I do. The other part is very exercise-based. If you McNeil-based, I don't know that you have to go to McNeil, but I think that that program works really well for this population. And so it makes sense that we're starting with an instrumental, that we're basically increasing the number of swallows, increasing the size of the bolus to add load so that you build the muscles back up, and then increasing the viscosity as you go through as well. So that was basically my treatment plan for him. And go ahead and go to the next slide. And the outcome. This was actually a fees that I did in November, and this is just a snapshot in time, I know, but if you read through the modified, you'd see, where he started from. And here you can see very little internal lymphedema. Swallowing is exercise, and Shelley will say exercise is good for lymphedema. And so swallowing is good. Lots of swallowing is good. So you can see good base of tongues here, very little fibrosis or scarring of the epiglottis and the larynx. And so that's a pretty happy little larynx. And then go ahead and go to the next slide. So yay, PEG was removed. I was this little guy was eating like well, but was still losing weight. He got down to 112 pounds. He was just like itty bitty. And so I was like, oh, I need help. So I got my dietitian friends. I'm going to let Crystal jump in here.
Yeah, so that'd be someone where obviously their weight should be fairly stable if they're taking the same amount of nutrition. And if he starts losing, then we start to question, does he have any recurrences? Does he need to be pulled back in to see his med-onc and follow up with his scan? Is this TSH off because of the radiation treatment? So that would be a kind of a clue for us if we're continuing interventions of increasing calories and it's not seeming to help at all, then that's kind of an automatic referral back to either the med-onc or the PCP.
Perfect.
So thank you all for your cases. Our final case of the night is a special case with a patient and clinician perspective. So I am going to introduce Tracy, who is going to walk us through her case. Hi, Tracy.
Hi, how are you tonight?
Good.
Can you see me?
Yep. Yes.
Okay. My name is Dr. Tracy Bender. I'm an occupational therapist and a CLT in Lincoln, Nebraska at a large outpatient cancer center. And I'm the rehab director there. We started this program about 5 years ago, and it's grown exponentially over the past 5 years. So we do not have a speech language pathologist in our facility, but we do have PTs, OTs, and 4 of us are CLTs. So we do refer out to a very experienced speech language pathologist in our area, and she's been able to work closely with us. So we're fortunate about that. The patient that I'm going to talk about tonight is a 45-year-old male who was diagnosed with base of the tongue cancer. He is kind of a unique case, and because he was a unique case, I feel like we're very fortunate to get the opportunity to kind of show our physicians how important early intervention is. He is a college football coach and was a previous NFL player. So he was a very physically active person prior to dealing with his cancer, but his job was extremely demanding. And so trying to figure out how to go through head and neck cancer treatment and all of the residual effects on top of being a college coach, that was a difficult feat for him and his family. When he started, he went through concurrent chemotherapy and with cisplatin and radiation and completed his therapy in April. And I received a referral for him right after he was done with this. And he was really struggling with a great deal of really thick mucus. He had already developed quite a bit of lymphedema. And he came in to our first session with a suction canister and basically said, I feel like I'm about to suffocate, literally suctioning 20 hours a day, not sleeping, feeling very panicked, like he, just couldn't breathe, couldn't do anything. So we started right away doing manual lymph drainage, and he responded that very quickly. The secretions started to thin, the swelling started to go down. Now he's a stellar patient in the sense that he did everything I told him to. So I think that was really beneficial. He was really compliant with everything, and I think that led to really good results. When he was able to tolerate, we got him in with a speech language pathologist. He had a swallow study. He had a feeding tube, and he was very determined to get rid of it, but he had lost a great deal of weight. So we kind of needed to work slowly with that. So he was able to get it removed. He did still have some difficulty with swallowing when it was removed, but he worked with the speech therapist and then also had the benefit of the training table at the college, making him very high protein and high nutritional smoothies to get his weight up and kind of help him through that period. He does still have some limitations with food. He said he really needs to eat a pretty bland diet and stick with pretty basic things. He has strong reactions to things like ketchup, but otherwise textures, he seems to be able to chew and swallow most textures and liquids okay. And then we were able to add in physical therapy to address some of the neck stability, strengthening, and then he was having a lot of muscle spasms. So between PT and OT working together, he developed a lot of fibrosis, and he is somebody who had developed a keloid scar. He had a port scar just below the border of radiation, which was a keloid scar. And that actually created a band of fibrosis that came from the chest clear up into the base of the chin. So it was a challenge, and it caused a lot of problems for him. But we had to balance him gaining strength with breaking that down so that didn't cause him to lose stability in his head. So we were able to then get the Flexitouch on board for him once we had kind of broken down a great deal of that fibrosis. And he probably should have been in that a little bit sooner, but he was on the road traveling for his work. And so getting him into that was a little bit delayed. But once he started with it, he really did well. If you want to go to that next slide. The picture there was within a week of him starting to use the Flexitouch. So he does still have visible lymphedema there, but it was very soft. We had broken down most of the fibrosis, and he was doing some compression, but he really responded very quickly to the Flexitouch. this was nice because when he was on the road and he couldn't get to treatment, he was able to still treat himself. And he definitely made time in his day, even if it meant he only had 3 hours of sleep to get that Flexitouch on.
Well, you did so good.
Yeah. So, and it still travels with him. So he'd call me from the road and tell me what was going on. And he'd say, but I have my pump with me. All right. And if we can go that, there's, so what I really, the reason I wanted his case presented in this is because I feel like he's the ideal success story of what early intervention can do. I believe it was Sherry that mentioned prehab, and that is the most ideal. So we can give some education and give a patient a little bit of warning, and also give them some ways that they can participate in their care. But the early intervention with the 3 disciplines, and, you know, obviously the dietary part is important, and then addressing any psychosocial and emotional effects, because these patients struggle so hugely with this quality of life change. And that was one thing that I hadn't heard mentioned yet. We do focus some on meditation. We have a meditation CD that we produced for our patients to try to help get them into a good headspace and deal with some of the anxiety, or some of them have a lot of claustrophobia because of the restrictions that they're feeling. So he has told me multiple times how grateful he is for the treatment that he received. And, you know, with the ongoing Flexitouch and doing at-home treatments with his family involved, he doesn't feel like he would have likely been able to return to his high pressure, high demanding job without having this intervention. So I just think that he's a really great candidate here to show what all the right parts and pieces can do to help somebody recover.
Yeah. Thank you so much for sharing this story. First of all, the work that you and your team did is incredible, and his progress is incredible. And like you said, these patients have so many issues that they're dealing with chronically, and then the psychosocial factors as well play such a big role in their ability to make progress. So I'm really happy that you brought that point up, because we hadn't addressed it yet. So I really appreciate you coming on and sharing this case, because it really shows what interdisciplinary collaboration is capable of.
Great job, Tracy.
Yeah, thank you.
So now we are going to open up the floor for Q&A. We thank everyone who submitted cases, and now we are going to ask our panelists whatever questions you all have for us. So we've got a couple of questions already. Let's see here. Okay, so how would you tell the difference between radiation fibrosis and fibrosis related to lymphedema?
I can take that.
Yeah.
So fibrosis of lymphedema, you're looking in the interstitial space, so it's going to be very superficial. Where radiation fibrosis, you will feel it in the muscles underneath. So it's a deeper, it's important that you pick up the skin and move it around, that it's not just a superficial, but that you're going much, much deeper in and feeling the muscles. It's actually, radiation decreases the blood supply as well as changes the makeup of the muscle cells. And so they very quickly, it's a decreased blood supply, so they get hard, they get fibrotic. Does that make sense?
Yeah. Yeah, thank you very much for answering that, Shelley. And I did just want to mention before we go to our next question that the patient from the last case that we just had is actually here with us this evening. So if anyone in the audience has any questions specific for him, feel free to post them, and we will ask for his input. Okay, so the next question is, how do you tell the difference between, we got that one, sorry about that. Okay, next question is, what kinds of exercises is the PT recommending at the initial visit?
So at the initial visit, I really focus on education, and I try to keep it simple. So I do neck extension, rotation, both directions, side bending, shoulder shrugs, and shoulder retraction to get them start working on posture. Just in case I don't see them again for a week or two. But those are my first. And then on the second visit, we add more, we make the extension more difficult. We also add pectoralis stretches, and if there's shoulder issues, we do wall climbing the first treatment. But then we do neck retraction and continue to work on the postural assessment, doing what we need to do to correct the posture.
Kelly. The next question is in regards to the prehab program that you mentioned, Joy.
Yeah, so it's called. It's also from MD Anderson. I think they coined the term pharyngosize, and kind of depending on where the tumor is and kind of what symptoms they're having, I feel like you need to really focus on, number one, making sure that they continue to eat and drink all through their treatment. And I know that Crystal reiterates that as well. And so they have to keep eating and drinking. I say no spitting in a cup, please. Don't come to me with a cup. You need to be swallowing. And then I typically have one, I could do like the Masako. So we're focusing on base of tongue because we know the base of the tongue atrophies and gets stiff. I might have them do like laryngeal elevation, like falsetto kind of exercises, tongue resistance for base of tongue, effortful swallow, supraglottic swallow. That's kind of tailored to each one. And so I try not to choose 10. I try to choose like 3 or 4, but they're typically targeted to where their treatment is focused. You know, if it's base of tongue, if the radiation is going to go to the base of tongue mostly, then we need to think about like, what can I do to make sure that the base of the tongue does not go on to get fibrotic? And so I think that those exercises should change depending on their diagnosis and where the treatment is.
Yeah, thank you very much. The next question is, you mentioned the importance of early identification of lymphedema/fibrosis. At what point is manual therapy introduced, especially considering flaps, reconstruction, and importance of wound healing? So we'll ask that part first, and then I'll ask the next part.
So I traditionally get I see patients from 2 different facilities, Mercy Hospital, and then Washington University, St. Louis is also here that I see patients from. Mercy Hospital, I tend to get them at 6 weeks post-treatment. And by then your collagen fibers are laid down. It's okay to do it around flaps. Now, if there's wounds in the mouth, on non-COVID times, I would, as long as there's not wounds in the mouth, I would work in the mouth on the edges of a flap. But if there are wounds, we do not work around it. And then, so if there is, what I was speaking of is if the patient has had surgery and that surgical swelling has not cleared up by 3 to 4 weeks, I would try to get them in as soon as possible. Usually our patients go 8 weeks from surgery before starting radiation. So that would give me a few weeks to try to get that swelling out of there. The patients can usually tolerate manual lymph drainage up until the 2nd or 3rd week, and at which point I would put them on hold, because then you're starting to get the skin reactions and they might not tolerate it. Now, if they have great insurance, a Flexitouch is a great possibility. Patients might not be able to handle our touching because we have a body temperature, but the Flexitouch does not have heat. And so patients can tolerate the Flexitouch during radiation better than they would be able to handle manual lymph drainage.
Awesome. Thank you, Shelley. The last part of that question was just, would you need to get an order or clearance from RADOC and or ENT before you start your intervention?
Absolutely. As a PT, we always have a referral from the physician. And it's usually the speech therapist, if she sees a significant issue where she's seeing them 2 to 3 weeks post surgery, if she sees an issue, then she usually initiates the referral through the ENT.
So the next question is actually for our patient. This participant wants to know how the coach feels that his daughter does with home MLD.
Really well, actually. She helps me out quite a bit when I was getting all my treatments. She would come in there from time to time and learn some of the things. So it's actually been pretty cool to have her be able to help me out.
Great.
Awesome. And I want to say thank you for being on with us this evening. It's so great to have you.
Oh, thanks. I appreciate it. It's a cool deal, and I'm glad to see there's a lot of people out there providing all the care that everybody needs. And I've told Tracy this on a bunch of occasions that I can't believe that not everybody gets the same treatments and some of the things that I got. It's not standard of care for a lot of people. It blows my mind that that's the case. So I wouldn't be able to do what I'm doing. I'd have to change my career and completely retool my life if I didn't have the treatments that I had.
Can I ask a question?
Thank you for being here.
Sure.
Tracy had mentioned claustrophobia. Did you have issues with that?
I didn't have any claustrophobia per se,
Okay.
but there's, a lot of the other things that I've heard this evening, absolutely.
So I specifically was wondering if you had a problem with the Flexitouch, feeling claustrophobic.
No.
Great.
Nope, not at all.
I know I've had patients before that we just suggest you start with the chest piece only and let them work through that, and then they can open the headpiece and just lay sort of against it as it's going and wean into it. So I'm glad.
I was literally trying to put that thing on the second I got it. So
that's awesome.
Yeah.
You look great. Good
Thank
job.
you very much. I appreciate it.
You would not have gotten as good a results if you didn't participate as much as you did with Tracy. So that is also key.
Yeah, she's like a football coach, so you don't really get many options when she's working with you.
You're back to eating
all my patients, be grateful you're not married to me or you're not my kid, because I have no mercy.
No.
So we actually have another question for you. A panel or someone in the audience wants to know if you can share your experience with pre-treatment counseling and how this impacted your course of care. She said, I have issues getting my oncologist to refer for pre-treatment counseling because they're afraid that the patients will be scared and not participate in treatment.
So I really didn't. That's a really good question. I have always been of the opinion, for me personally, I wanted to know as much as I could possibly know about what was going to happen to me. And my wife and I have spoken about this a bunch. We felt we were honestly not very prepared for all of the things that could happen. I had no idea I was told, hey, you're going to lose some weight. This is not going to be very fun. You're going to have a sore throat. That's essentially what I was told. So from the reality of it, I ended up losing over 100 pounds and it was insane. So I don't know that we were, I would say the pre-treatment counseling was nil. And I wish I would have had a whole bunch more than what I had. I think of just the opposite, just my own mental approach. I want to know everything that's going to happen before it happens so I can prepare myself mentally for it. For me, that I would have preferred more information and just let me know what's going on, as opposed to, you walk in and 6 weeks after you get your last chemo or radiation and they say, hey, good job, we'll talk to you later. And then 6 weeks later, you can't swallow or eat and you're wondering what's going on. So I would prefer to have all the information given to me up front so I can, essentially prehab myself in terms of nutrition and working out and making sure that I've given myself the best chance to minimize all the effects that I can.
Did you work out through your treatment?
I worked out. So I continued to work until I got, I think about halfway through or 3/4 of the way through. Obviously with the chemo, I couldn't sleep very much. It screwed up my ability to sleep. So there were many times as I still could, I would be up, 3 or 4 in the morning on the elliptical watching Netflix. So I've seen about every food documentary there is possible on Netflix. So I did that for as long as I could. And I do think that was a huge, the two things that I thought were some of the biggest differences for me was, I had some nutrition that was available to me through coaching over at the University of Nebraska that probably is not available to almost anybody. We had an army of nutritionists available to us at all the times. I had a protein nutrition shake that was 1,000 calories every time I took a shake. So that made 4 of those a day. I was so nutrient dense. It was unbelievable. And they're giving me Juven and all other kinds of supplements that I could take to help rebuild tissue as fast as I could. So all of those things, it was just like the prime situations. If you can do this, you're going to be a lot better off for it.
That's great.
Awesome.
Yeah.
We have a couple more questions for you.
Sure.
Someone in the audience wants to know if you were performing self MLD and using the Flexitouch, and if you felt that one was more effective than the other.
If I was doing, say that one more time, I'm sorry.
If you were doing self MLD at home and using the Flexitouch, like if you were doing both in conjunction, and then if you felt that one was better than the other.
Honestly, I thought the Flexitouch was one of the most effective things I did, because it just, I don't know why, I don't know how, but when I would wear it and I would take it off, and I think I was able to do it like once every 8 hours or something like that. I can't remember what the pattern was. But when I was able to do that, like it just opened up. So you could actually, like the first time I did anything, you could hear the fluid draining. It was really an eerie sound. But once I did that, that was probably the most effective thing that I did. I mean, whatever Tracy told me to do, like that was going to happen. I had to do different exercises, and I was going to do that every hour. It's just what it was going to be. So I would wake up at night and do what I was told to do. So I mean, that's just how it worked for me. But I really, the Flexitouch was a really big deal for me in recovery. Really big deal.
Yeah, that's so great to hear. We have somebody in the audience that knows you, Trevor. He said, "Not a question, but thank you for your time tonight, Coach. Go Tar Heels."
Hey, what's up, Trevor? That's funny. That's really funny.
Okay, so we have a couple more questions for our panelists. Okay, so the Flexitouch may be helpful for patients who had radiation only, but for patients with radiation who also have neck dissection and have less lymph nodes, is Flexitouch looking at a method for the routing of lymphatic fluid being routed to a posterior drainage approach as the current Flexitouch flow routes to cervical lymph nodes?
I've not had any issues with it needing to be rerouted, especially since everything drains below the ear, your main drains, whether it's anterior back or posterior forward. So as it has been effective with all of my patients, and I would say at least half of my patients, if not more, 75% are neck dissection. And it doesn't need to be rerouted, especially you need to route that fluid through the scar tissue. It's got to open up. And so the Flexitouch in a very gentle pressure is helping to facilitate the lymphatic drainage, facilitate on the involved side and uninvolved side. And it's also helping to lay the collagen down in the scar tissue so that it can open up and everything drain through.
Thank you, Shelley. We have another question for you. Someone in the audience wants to know, are there any effective head and neck garments, daytime or nighttime, that you have found effective for long-term lymphedema management for head and neck? Is there a specific style or brand that you have found to be more comfortable and properly fitting?
There are many out there. I don't particularly like one better than the other. I make my own using a product called Fibrofoam, and then I make my own chip pack using Comprex, which I'm doing about 1/2 centimeter squares. And I make my own chip pack to whatever is needed. So I think that was the products out there. Some of them are great, especially if you've got a full involved space. But with patients that only have little pockets of swelling, it's kind of overkill. So that's why I like to make my own little, I think some people call them Schneider packs. I call it a chip pack. And then I use Fibrofoam to hold it into place.
Thank you. Our next question is for you, Joy. They want to know, what are the indications for myofascial release and what discipline typically does this? And they specifically want to know if it's out of the scope of practice for an SLP, and then what is the process for certification?
Yeah. So as far as I know, I've taken 2 trainings. There are PTs out there that are that love speech pathologists, and Walt Fritz is one. Yay, Jelly! Um, and then John Kelly through Chow Seminars offers wonderful courses for speech pathologists, and I would highly recommend both of them. They're different, like different philosophies. But those are the 2 that I know for sure. There's not like letters that you get or a test that you take that say that I'm certified in that. But like I feel that both classes were beneficial, and that we are qualified to do that, because I feel like nobody knows the head and the neck better than we do, and especially for the intraoral things. When you stretch somebody's tongue for the first time, what do they say to you? They say, thank you, because their tongue is tight. And so you just cannot get, nothing else that we do is so dramatic. Like it's just such a huge change for them. So besides like I'm, exercise based, but like this is within our scope of practice, and we should be doing this, especially if you do a lot of head and neck, because there's so much benefit to it.
Mm-hmm.
Yeah, Joy, I also have done courses for myofascial release / manual therapy. And the first time you do the intraoral massage on someone, it is so incredible to see the look of relief on their face when they realize they don't have to have all of that tension.
Yeah.
So
huge.
Yeah.
Okay. The next question is also, again, for you, Joy. Shelley, did you have something you want to add?
Well, they also, in that question was, they were asking about who does the manual lymph drainage. I think I can only speak of my practice, but very often the speech therapist will see the patient from, 1 week post-surgery to say 6 weeks post, and she does follow-ups after that. When she refers to the CLT, I usually take over at that point. Like I have so many things to work on, but I also do myofascial release, and I'm doing purely external. I do work on the grafts or on trismus. So, I don't think that there's an issue with overlapping services because we are, there's so much involved and what these patients go through and their quality of life that, Joy, do you talk to your CLTs about I'm still doing myofascial release or?
Yeah, so they, the ones that are in town, I feel like we get good follow through. Unfortunately, Iowa is kind of rural, and so it's hard to find, in rural Iowa, a CLT sometimes, and so. You know what I mean? Like you're kind of rare, like especially someone like you who is really comfortable. And so, I had one recently where I referred for, in significant internal lymphedema, and the therapist called me and is like, can I do that? Can I help that? And, just really didn't know, because, I have case studies that I can show that internal lymphedema is helped by manual therapy and by the Flexitouch. Like I have pre and post pictures. And so I know that you can help. Like I know that what you're doing is helpful for my internal lymphedema.
Well, patients say that too. After we're working externally, they're saying my swallow is so much better. Mm-hmm. So we know that it is helping. And I wasn't always comfortable with it. Since I'm standing massaging for an hour, I have anatomy up next to me, and I'm constantly learning the muscles of mastication. And I'm constantly researching all this out so that I can not get grossed out at your speech pictures of your scope, that I actually know what that anatomy is and I can name it. And so it's taken me a long time to get comfortable at the anatomy of the neck and mouth.
Tracy is still on the line with us. So Tracy, I want to get your opinion on this. I know you mentioned that you have a speech pathologist off-site. Do you see an overlap in disciplines with your patients?
Yeah. One thing that I wanted to mention really quick about Javon, we for head and neck don't have a prehab program, but we're trying to develop that. It's pretty standard with breast cancer, but it doesn't come along as fast in other areas. So the speech language pathologist that I work with the most is actually on the call. So she's watching tonight. I saw her make a comment. Hi, Polly. So we do as much of the interdisciplinary care as we can within the facility. We have an in-facility dietitian. We have OTPT. I wish that there was just a standardized way that these referrals are being made, but a lot of the head and neck treatment in our area is actually being done about an hour away at the University of Nebraska Medical Center. So that's where the major surgeries happen. And that's where a lot of the oncologists are seeing those patients. So a lot of them that come or live in our Lincoln area are coming back for radiation in our area. So we're getting random referrals. Some of it is really good on the radiation therapist or radiation oncologist part, where they're saying, hey, we're going to start radiating this person in 3 weeks. Take a look at them for me. Or they just got done and they're having some swelling. But some of them are coming to us 10 years later with a lot of fibrosis. We're getting a lot of random things, but we will be developing a new cancer center in a couple of years. And so we're trying to kind of streamline everything so that we're providing the care that I'm suggesting, and it just needs to be happening. So we're trying really hard to get everything in alignment so that we have that available for every patient.
Yeah. Did you have anything else that you wanted to add?
The gal that is the physical therapist, is it Sherry?
Shelly.
Kelly. Okay. Yeah, I love some of the stuff that you're saying. One thing that I would like to say, because there was a couple of questions about the difference between lymphedema and fibrosis. I really just kind of naturally through treatment go back and forth between MLD, scar tissue management, myofascial release, and I'm sure you do that too. Absolutely. So I would just do, if you get something that it does feel really superficial and you can tell that it's lymphedema and maybe not fibrosed yet, the manual lymph drainage is great. When you're dealing with even fibrotic lymph tissue, and then you can still see kind of that when you pull the skin and you see that real striated, I kind of just go back and forth and keep addressing it. But I think it's so important to keep the MLD as a part of the whole treatment, because as you break down that scar tissue and fibrosis, the tissues swell. So then you want to keep going. So yeah, it's I think with Javon, I'm sorry, my patient that was on here speaking with us, he had a lot of fibrosis. He had a lot of lymphedema. Initially, once we got that taken care of, his fibrosis was just terrible. And that was what was limiting him so much. But I always had to do a lot of MLD with him, because as soon as I would really get somewhere with the scar tissue, then he'd swell back up again.
Yeah, I couldn't have said it better. The further out they are from treatment, the more likely you need to be more aggressive with the hard fibrotic tissue, and you follow it up. I tell people I make your tissue angry, and then I follow it up with MLD, make it nice, trying to calm it back down. And I always end it with MLD, strokes to calm down anything that I've caused.
Yeah.
So we are just about to close. There are several questions in the chat in regards to whether SLPs can become trained certified lymphedema therapists, and then whether myself or Joy, whether we are certified or would we defer to a CLT. I know in my personal experience, I had a CLT on my team that I work closely with, so I didn't pursue that certification, but that was just because of my experience, I didn't need to. Joy, what are your thoughts on this?
Yeah, I was actually signed up. There's a head and neck specific one through Brad Smith, I think, and I was signed up to do that before the world stopped turning in March. So that's something that I am really interested in pursuing. And, I know there's a few speech pathologists who have their full CLT. So I think it's a great idea to at least do the head and neck to have a better appreciation for that, so that we know when to refer early.
So with that, we are going to go ahead and close for this evening. If you have friends that were wanting to get on this evening and weren't able to, there will be a replay up of this webinar, and that will also allow you all to go back and review like the information Shelley, Crystal, and Joy provided, and Tracy. If you want to go through images or anything like that, as always, feel free to reach out to us with any questions. And thank you so much for being here with us tonight.